Hi everyone, it's Dr. Campbell with a CPT surgery coding review, where today we're going to focus on the 40,000 series of our CPT code set, which begins on page 297. And here you will find the digestive system, codes 40490 through 49999. On page 297, you will see that the digestive system is divided into what I like to call a head-to-toe organizational structure. So the first set of codes that you're going to see are codes for procedures on the lips, and then the last set of codes that we have here are for procedures on the abdomen, peritoneum, and the omentum. One of the things that you will notice as you explore the table of contents for the digestive system is that the codes have a particular format, if you will, related to the different types of procedures. So when you have an opportunity, and I know that you will, take a look at your table of contents, specifically the wording that's in blue underneath each body part. The body parts are in red. But you're going to notice that you're going to see procedures like incision, excision, manipulation, destruction. And one of the things that you want to be very important to take note of is that you not only want to make sure that you have the right procedure, but you also want to make sure that you have the right body part via the correct approach. In this particular section, I want you to note that you are going to see some endoscopy procedures. I do want you to remember that from a gastrointestinal tract perspective, you have the upper gastrointestinal tract and you have the lower gastrointestinal tract. Your upper GI tract is where you're going to see procedures such as esophagoscopy, esophagogastroduodenoscopy, endoscopic retrograde cholangiopancreatography. You also are going to see lower GI tract procedures such as your proctosigmoidoscopy, your sigmoidoscopy, and your colonoscopy. And we'll take a look at several of those procedures today. We're going to begin our journey into the digestive system by taking a look at the procedures on the lips. Now, one of the things I want you to notice, and I know that you guys are very familiar with this by now, but I want you to notice how in this particular area, for example, if you look at excision, specifically code 40510, you'll see excision of lip, transverse wedge resection with a primary closure. But underneath there, you see other options of excision of the lip procedures, but they're divided based upon the procedure itself. Additionally, don't ever forget about our friends in parentheses, because they are very important in terms of promoting correct code assignment. Also on page 300, if you go to repair, I want you to notice at code 40700 for the plastic repair of the cleft lip / nasal deformity, that your first code is divided into primary. And primary is further subdivided into partial or complete, and notice that that particular code is unilateral. But then notice how as you transition to 4070102, those codes are also primary, but they are bilateral in nature. And then 40720, notice that particular code states secondary. Very, very, very important. Also, as you look at this particular area, you'll also notice more parenthetical notes specific to certain reconstructive procedures. Be sure to read those parenthetical notes because they are so very important. Next up, on page 300, we have the vestibule of the mouth, and this is essentially part of the oral cavity outside of your dental alveolar structures. This particular area includes the mucosal and submucosal tissue of the lips and cheeks. So here you have incision, excision, repair procedures. I want you to take care in looking at the differences in those codes. For example, 40810 is an excision of a lesion of the mucosa and submucosa, and this is without repair. The subsequent codes get into actual repairs and specific types of repairs, simple versus complex, and then complex even has an option for an underlying muscle. Under this particular body part repair, 40840 with your vestibuloplasty, notice how this particular code family is divided into anterior, posterior, unilateral, bilateral. Guys, details are critical. Okay, next up we have on page 301 procedures on the tongue and the floor of the mouth. So here, guys, you're going to see several types of procedures. Under excision, we have an intraoral incision and drainage of an abscess, cyst, or hematoma. But I want you to notice something. Take a look at 41015. That is an extraoral incision and drainage. So very important. Again, you want to have the right body part as well as the correct procedure via the correct approach. Then we have procedures under excision, same family, tongue and floor of mouth. And here I want you to notice, as you look from page to page, you see some of the same types of procedures being performed, biopsies and excisions, but again, specificity regarding that body part is going to be critical. Next up, we have on page 302 procedures on the palate and uvula. And here, guys, same thing, incision, excision, repair. And I want to take note of wording that you're going to see a lot in the surgery section, primary versus secondary. So primary means that this is the first time that the patient is having this procedure in most cases, whereas secondary means that they've had the procedure already and they're coming back for a secondary repair or secondary service. Next up, we have the pharynx, adenoids, and tonsils on page 303. And in case you're wondering, yes, this is where your tonsillectomy codes are available. So if you take a look at 42820 on page 303, the first thing that you're going to notice is that your tonsillectomy codes have some very specific characteristics. Number one, you can have a tonsillectomy and an adenoidectomy performed on the same day. These codes are divided based upon the patient's age, over 12 or younger than 12. Also want you to notice there's an option for tonsillectomy only. Notice it's divided into primary or secondary, meaning this is the first time the procedure was done or the second. We also have adenoidectomy procedures only, and I want you to take note of the fact that, again, age is a factor. All right, next up, guys, we're going to look at procedures on the esophagus starting on page 304, and what you're going to see here again is different types of procedures. So we're starting off with our incision and our excision, but I want you to notice under excision some very specific details about the excision procedures. I want you to notice in 43107 you have total or near total esophagectomy. But then when you go over to 43112, you also see total or near total esophagectomy. So the question is, well, what's the difference in those codes? Well, one main difference is 43107 is without thoracotomy, 43112 is with thoracotomy. Then as you continue down that particular page, page 305, the other thing that you'll notice is that the procedure transitions into a partial esophagectomy. And there are several partial esophagectomy procedures, so you'll want to take note of the specific details in this particular code family. Next up, we have esophagoscopy procedures. Now, one of the things I do want to remind you about as it relates to the digestive system is paying attention to the path of the scope. Was the scope inserted via the mouth, or was it inserted via the anus? So an esophagoscopy is a procedure in which a flexible endoscope is actually inserted through the mouth. It can also go through the nose, but it's going to go down into the esophagus. As illustrated by this diagram here, at the end of the esophagoscope, there is a device that is designed to magnify images on a screen. And one rule that I want you to keep in mind is we don't code where the scope is entered. We code to the fullest extent of which the scope was examining. In your CPT manual on page 305, there is a notation of what is included in an esophagoscopy procedure in terms of the different areas that the scope is examining. Please pay close attention to that level of detail. I do also want you to notice, and I know that you're going to take a look at this. When you look at page 305, you'll notice that those codes start off with esophagoscopy, rigid. We have transoral as an option, but then you have on page 306 transnasal code options as well. You also want to notice that these codes are divided based upon the different types of procedures that are being done, so please pay careful attention. Of note, guys, there is a video and a technique called bubbling. It's the BHAT technique. I highly recommend that you check out that video and that approach. I think that is an excellent approach to marking up and bubbling your CPT manual, especially if you're going to be taking a national exam. So just Google CPT bubbling technique and you'll find that resource to be an amazing option for someone that is trying to learn how to use their CPT manual as well as understand the notes that are contained therein. All right, next up we have our esophagogastroduodenoscopy procedures, and those begin on page 308. And this is another upper GI procedure. The scope is going to be inserted through the mouth with a goal of looking at the esophagus, the stomach, which is gastro, and then the first part of the intestine, which is the duodenum. Reading the operative report is going to be critical in determining the extent of the procedures that were performed. Keep in mind that you may have more than one procedure performed on that day. You can have dilation, you can have removal of foreign body, you can have a biopsy. Very important to take note of the specific details. And guys, watch out for those parenthetical notes because they are all over this particular code family. Next up, we have our endoscopic retrograde cholangiopancreatography procedures, also known as ERCP, which begin on page 311 with subsection notes. ERCP is actually a procedure that allows the provider to examine the pancreatic and bile ducts. Here, you're going to have an endoscope that is inserted, of course, through the mouth into the stomach and it down into the first part of the small intestine, which I'm sure you know by now is the duodenum. These codes are designed to diagnose and treat conditions such as gallstones, cancer, as well as strictures. So when you're taking a look at those codes, you got it. Watch out for those parenthetical notes, because some of the codes identify things like you can only report this code once per session. It may tell you that that code includes multiple biopsies all in one code. The devil is in the details. Very, very important. Next up, bottom of page 313, we have our laparoscopy procedures. You know the term laparo means that an incision is going to be made into the stomach. So with a laparoscopic procedure, here the focus is on our digestive system organs. This is where a scope is inserted through the abdominal wall to view the organs of the abdomen. A laparoscopy is also a part of a lot of other procedures, so be sure to pay close attention to the wording and make sure that this procedure is in fact a procedure on the digestive system organs when you're looking at the codes 43279 through 43289. All right, next up we have our body part of the stomach, and what we're looking at here, going over to page 319, and this is where you have your bariatric surgical procedures. These procedures may involve the stomach, the duodenum, the jejunum, and or the ileum. I want you to note that these procedures are laparoscopic in nature for the first family of codes, and then we also have procedures that are classified as other procedures. So as it relates to our procedures on the stomach, bariatric in nature, you have procedures such as your Roux-en-Y, aka your gastric bypass, as well as your vertical sleeve gastrectomy. All right, next up we have intestinal transplantation codes on page 321. So one thing that you're going to notice, and I've said this before, is with your transplantation procedures, the CPT code set defines 3 distinct components of work. In this particular case, we have the cadaver donor entrectomy, we have the backbench work, and then we have the allotransplantation. Those are your 3 distinct components of work: cadaver donor, backbench, and then the recipient allotransplantation. All right, next up we have endoscopy, small intestine procedures. Now guys, one thing that I want you to pay close attention to is where that scope is being inserted. So on page 324 for endoscopy small intestine, these procedures are specifically for procedures on the small intestine. Here you have codes 44360 through 44379. Yes, you guessed it, more subsection notes, more parenthetical notes. Now next up guys, we have codes for endoscopy stomal. Now I want to build awareness about something. On page 325, you're going to see the words proctosigmoidoscopy, sigmoidoscopy, colonoscopy, colonoscopy through a stoma in terms of definitions. This family of codes right here, guys, focus on these procedures that are done through a stoma. As you know, a stoma is an opening. So on page 326, 27, you're going to see these different procedures that are classified as being performed through the stoma. This is important to note because those same procedures, proctosigmoidoscopy, sigmoidoscopy, colonoscopy, you're going to find that those procedures are going to be listed further in the manual as well, but they're for situations when there is no stoma. All right, so speaking of Proctosigmoidoscopy codes. These codes begin on page 330, guys, in your CPT manual. Now, as it relates to these specific codes, your proctosigmoidoscopy, I do want you to notice that there are some extensive notes. There are extensive parenthetical notes. These codes are divided based upon what they actually do upon entering the proctosigmoidoscope. So those codes are on page 330. A proctosigmoidoscope is the examination of the rectum and may include examination of a portion of the sigmoid colon. Guys, but then on page 331, you have your sigmoidoscopy codes. Now here, guys, same thing. Parenthetical notes, you have your different ways the procedure is performed. You have subsection notes. A sigmoidoscopy procedure of note is the examination of the entire rectum, the sigmoid colon, and may include a portion of the descending colon as well. All right, next up, guys, we have colonoscopy codes. Those colonoscopy codes begin on page 332. I want you to take note of the colonoscopy decision tree, which is on the top of page 332, which divides your colonoscopy procedures by several components. Number one, was this a diagnostic colonoscopy or was this therapeutic? Other questions that the decision tree will help you answer is, did the surgeon reach the splenic flexure? Did the surgeon examine all the way down to the cecum? And then I also want you to take note of the fact that there are coding tips, parenthetical notes, you name it, guys, it's there. Please, please pay attention. But I do want to remind you, these last three codes that we looked at, remember, those were not via a stoma. These codes that we just started looking at, page 330, those were via a stoma. All right, next up, we have our hemorrhoidectomy procedures. Now, our hemorrhoidectomy procedures are on page 336. And what I want you to notice as it relates to the hemorrhoidectomy procedures is that they are divided based upon the type of hemorrhoid and actually what's done to the hemorrhoid. So was it internal? Was it external? How many columns or groups were impacted for this particular procedure? Next up, we have liver transplantation, and I hope you remember what I said a few minutes ago about the three distinct components of work because they are present here as well. All right, guys, next up, percutaneous biliary procedures. Now, the percutaneous biliary procedures start on page 340. And guys, I hate to be the bearer of bad news, but you know I must warn you, lots and lots of subsection notes, parenthetical notes, very, 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 very important, guys. So here you're going to see all sorts of procedures on the biliary area that are percutaneous in nature, such as drainage as well as stenting. Again, pay close attention to the details. All right. Also, in this particular family, we have codes for procedures such as a pancreectomy. As I'm sure you know, and we're on page 344, those are procedures to remove all or a portion of the pancreas. On page 345, you will find our pancreas transplantation codes, and in case you were wondering, yes, it is still those three distinct components of work: cadaver donor, the backbench, and the allotransplantation. Next up, we have gastrostomy tube procedures. Gastrostomy Sorry about that. I actually was sneezing in the middle of saying gastrostomy tube procedures. All right, so here, these codes are on page 349, and they are divided based upon whether it is an initial replacement on 349, a conversion, 350, replacement on 350, and then we also have procedures for mechanical removal of obstructive materials. Lots of parenthetical notes that you'll want to pay attention to. All right, guys, and our last set of codes here in this particular code family, we have our hernia repair procedures, which are on page 350. And one thing I want you to notice, on page 350, you notice it says hernioplasty, herniorrhaphy, and herniectomy. Guys, these are what I like to call our open procedures, because when you go over to page 352, you have still hernia procedures, but these are laparoscopic in nature. So when you are coding a hernia repair procedure, first you want to look at the documentation to determine what was the type of hernia. Was it incisional or was it excisional or inguinal? You also want to know the clinical presentation. This is actually also known as the diagnosis. So was it incarcerated? Was it strangulated? You also want to take note of the episode of care for this hernia. Was it a recurrent hernia or was it an initial hernia? You also will notice on page 351 that the codes are divided based upon age. Of note, a recurrent hernia is one that has previously been surgically reduced and then it comes back. Now, I did mention that you had laparoscopic repairs on page 352, but I also want you to notice on page 352 add-on code 49658. And 49658, this is when the patient has mesh implanted. Of note, mesh can only be used if this is an incisional or ventral hernia repair. All right, guys, thank you so much for listening and have a great day.